Today we're tackling a topic that, well, lots of people think they know, but it's often profoundly misunderstood. Obsessive-Compulsive Disorder, or OCD.
Right.
For this deep dive, we've gathered some really fascinating stuff. There's a recent study from right here in Prince Edward Island, which is interesting. Plus, articles from the International OCD Foundation, Healthline, and some critical research looking into media portrayals and that very personal decision about disclosing OCD.
And what's truly striking, I think, when you look at these sources together is how they really highlight this huge gap, this chasm between public perception and the actual lived reality of OCD.
It's a great way to put it, a chasm.
Yeah. So our goal today is really to try and bridge that gap, move past the common myths and misperceptions to understand what the disorder actually is, its real impact, why mental health literacy is so vital, and this pervasive issue of stigma.
And listeners, this deep dive is absolutely for you. Maybe you know someone navigating OCD, or maybe you're just curious and want to be genuinely better informed. Prepare for some facts that might actually surprise you. We're really aiming for those moments where things just click, those aha moments that might shift your perspective.
Oh, fully.
All right, let's kick things off with the absolute basic, but let's move beyond the usual assumptions quickly. At its core, how do our sources really define OCD? What are obsessions and compulsions, really?
Okay, so at its core, OCD is a mental health disorder, and it's defined by two key things: obsessions and compulsions.
All right.
Obsessions are those distressing thoughts or images or impulses that keep coming back. They recur, often feel really intrusive, unwanted, and they significantly disrupt someone's daily life.
Okay. Intrusive, unwanted thoughts.
Exactly.
Yeah.
And compulsions, then, are the repetitive behaviors or even mental rituals that people perform in response to those obsessions.
Okay, so they're linked.
Directly linked. The main purpose of the compulsion is usually to try and neutralize some feared negative outcome or just to reduce the intense distress that the obsession is causing.
I see.
And these two things, obsessions and compulsions, they don't just exist separately. They intertwine often in this relentless, debilitating cycle.
And here's where I think it gets really interesting, because OCD is incredibly varied, right? Many people might immediately picture someone who, loves cleaning or organizing.
That's the common stereotype, yeah.
But our sources really highlight how diverse it is. The common types of obsessions, sure, they include contamination, fears of harm or aggression, maybe needing order or symmetry. But then there are also those often misunderstood, sometimes quite repugnant thoughts related to sex or religion or violence.
Absolutely. And that's crucial.
What's key to grasp, I think, is that OCD can look vastly different from one person to the next.
Yeah.
Even within the same sort of category.
Yeah, exactly. And researchers often make a distinction here. They talk about autogenous versus reactive obsessions.
Okay, autogenous,
Yeah.
reactive. Break that down.
Right. So autogenous obsessions are deeply distressing thoughts that feel totally alien to the person, like completely against their values. We call that ego-dystonic.
Ego-dystonic. Got it.
Yeah. They often seem to just pop up out of nowhere without a really clear trigger you can point to. So imagine having repeated, unwanted, intrusive thoughts about, say, harming a child, even though that's the absolute last thing you'd ever want to do.
Wow, okay. That sounds incredibly distressing.
It is. And then reactive obsessions are maybe perceived as a bit more rational, or at least triggered by something external, like contamination thoughts that come up when you see a dirty toilet.
Ah, okay. So one feels internal, out of the blue, and the other is a reaction to something outside.
Sort of, yeah. But the really critical point here, stressed in the sources, is that it's the interpretation someone attaches to an intrusive thought rather than the thought itself that transforms it into an obsession.
That's a crucial distinction that I think often gets missed.
Yeah.
So it's not the thought itself that's the problem, but the relationship you have with it, the meaning, the fear you attach. Can you give an example of a common intrusive thought that isn't an obsession for most people but becomes one for someone with OCD?
Absolutely. That's a great question. Think about something really common like a fleeting thought crossing your mind that maybe you left the stove on after leaving the house.
All right, yeah, happens to everyone.
Right. For most people, that thought pops in. Maybe you do a quick mental check or just dismiss it, and then it's gone. It's just a normal intrusive thought.
Right.
But for someone with OCD, that exact same thought can become a reactive obsession. It's triggered by the external stimulus leaving the house. But their interpretation is that this isn't just a maybe, it's a potential catastrophe.
Ah, the meaning attached is amplified.
Hugely amplified. It leads to this overwhelming urge to check, maybe repeatedly, perhaps driving back home, checking for hours. It's that intense meaning, the resulting distress, and then the ritualistic checking that makes it an obsession, not just a passing thought.
And those compulsions then link directly back to these obsessions.
Exactly.
So for contamination fears, you might see the repetitive washing, the cleaning rituals.
Mm.
For harm-related fears, it could be that frequent checking locks, checking appliances, checking that no one was harmed by something you did or didn't do.
Checking for mistakes, yeah.
Or for obsessions around order or symmetry, it's often that constant arranging of things until they feel, quote, just right.
That just right feeling is a big one.
But it's so important to remember, and the sources emphasize this, that compulsions aren't always visible physical actions we can see.
Absolutely not. This is key.
They can also be mental rituals, right? Like counting in specific patterns, or maybe repeatedly reviewing past events in your head, trying to be sure about something, or even silently praying in a very rigid way.
Yes, exactly. And these are much less visible to others, obviously, but they're equally impactful, just as time-consuming and just as distressing for the person experiencing them.
So given all this complexity, this internal struggle, the visible and invisible aspects, what does this all mean for how society actually views and treats people with OCD?
Well, the sources are pretty clear that individuals with OCD face two main really damaging forms of stigma.
Two main forms, okay.
Yeah. The first one is trivialization. This often gets directed at people whose symptoms seem maybe less severe or more relatable on the surface, like the reactive obsessions, the symmetry stuff, or the contamination-related OCD.
Right, the stereotypes we see in media.
Precisely. Media portrayals often use OCD for, like, a comical effect, or they push this really narrow, damaging idea that, everyone's a little bit OCD.
Ugh, yeah, that phrase.
It completely invalidates the very real distress and the actual functional impairment these individuals experience. It makes their struggles seem minor or sometimes even like a desirable quirk.
Which is so far from the truth.
Mm-hmm.
What's the second form of stigma?
The second form is stereotyping as dangerous. And this often applies more to those experiencing the autogenous obsessions, the harm or aggression-related ones, or the sexual-related intrusive thoughts.
Ah, because the thoughts themselves sound scary to others.
Exactly. Because these obsessions involve thoughts that society generally deems taboo or frightening, the individuals experiencing them are sometimes seen unfairly as a potential threat. And this leads to a greater desire for social distance, for isolation.
Wow. So either trivialized or seen as dangerous. That's rough.
It's incredibly damaging either way.
And the impacts of this stigma, they must be huge.
Oh, they're profound, truly detrimental. Stigma reinforces these harmful stereotypes, obviously. It leads directly to discriminatory behaviors in housing, employment, relationships. It results in social segregation. It also actively erodes a person's sense of autonomy and self-efficacy. It makes them feel less capable, less in control. And maybe most critically, it significantly reduces help-seeking behaviors. People are afraid to reach out.
That's the real tragedy, isn't it? The thing that's supposed to help feels inaccessible because of judgment.
Exactly. Stigma can actually make the mental health condition itself worse. And it can lead people to go to extreme lengths. Like one source mentioned people lying to insurance companies just to avoid getting that label, that misunderstanding.
Just to avoid the label. Wow. Do we have any, numbers on this? How common are these attitudes?
Yeah, one study mentioned gives some concrete examples. It found that 7.2% of participants use terms like weird or crazy to describe someone with harm-related OCD symptoms depicted in a vignette.
7%. Okay.
And 5.5% use those same terms for someone with contamination-related OCD. Which, might seem like small percentages, but it illustrates these negative perceptions are definitely out there.
Yeah, absolutely.
And it really raises an important question. What factors, both individual and societal, actually contribute to these stigmatizing attitudes?
That's a vital question. Okay, let's unpack that. Who tends to display more of these stigmatizing thoughts and behaviors, and why, according to the research we looked at?
Well, the research consistently points to some interesting gender differences. Generally speaking, men are typically more likely to stigmatize individuals with mental health disorders.
Really? Why is that?
Sometimes it seems to be linked to assigning greater personal responsibility for developing the condition, like blaming the person. And this tendency can actually be more pronounced in men who have higher education levels or less personal experience interacting with mental health professionals.
Huh. That's counterintuitive about the education level.
It is a bit, yeah. Conversely, women generally show fewer stigmatizing thoughts and tend to prefer less social distance from individuals with mental illness. And interestingly, older women, specifically those over 25 in one study, displayed even fewer stigmatizing thoughts.
Okay, so gender plays a role.
Yeah.
What about age overall? You mentioned older women, but what about age generally?
Yeah, so the Prince Edward Island study we looked at had a particularly interesting finding here. They found a weak positive relationship between age and stigma.
Weak positive,
Yeah,
meaning older people showed more stigma.
that's what this specific study suggested, yeah. As age increased, stigma also tended to increase, though the relationship was weak. Now, this finding actually goes against some other research in the field.
Oh, okay, so conflicting findings. Why might that be?
Well, one possible explanation is that, mental health has only really become a widely discussed, more openly understood topic relatively recently. So older generations may simply have had less exposure to accurate, destigmatizing information about these conditions throughout their lives compared to younger people growing up now.
That makes sense. Less exposure, maybe more ingrained older attitudes.
Could be. And here's where the research really threw a curveball, delivering a genuine aha moments, I think.
Oh, you tell.
The PEI study found something completely counterintuitive regarding familiarity with OCD.
Familiarity, you mean like knowing someone with it or knowing about it?
Yeah, exactly. You'd naturally think that knowing more about a condition, being more familiar, would reduce stigma, right?
Absolutely, that seems logical.
Well, they actually discovered the opposite in their sample. Greater self-reported familiarity with OCD was associated with higher levels of stigma.
Wait, higher, not lower.
Higher, particularly among those who reported having been diagnosed themselves. They showed significantly higher stigma scores than those who reported no OCD or were uncertain.
Wow. That just flips conventional wisdom completely on its head, doesn't it?
It really does.
So what do you think might be going on there? That's genuinely surprising. Could it be that familiarity for some people means like seeing those trivializing TV shows? Or maybe if you're newly diagnosed, you're grappling with your own internalized stigma.
Precisely. I think you've hit on the key possibilities. If we try to connect this to the bigger picture, this unexpected finding could be down to a few things.
Okay.
It might relate to the fact that familiarity was self-reported in the study. So what people perceive as familiarity might not actually be deep, accurate understanding. It could be based on those stereotypes.
The superficial familiarity.
Exactly. Or it could be that participants who had been recently diagnosed were still really wrestling with the internal and external stigma associated with their condition. Maybe they're even harder on themselves or others because of it.
Internalized stigma.
Yeah. And another possibility, maybe the study's title itself attracted individuals who were already really deeply engaged with their diagnosis, perhaps in a way that involved internalizing some of that societal negativity. It's certainly a finding that screams out for more research, more exploration.
Absolutely. Fascinating. It's also worth quickly mentioning the sources note how the causes people attribute to mental health disorders play a role too, right?
Yes, definitely. Attributing problems to, say, personal failings, like blaming poor parenting, that tends to significantly increase stigma.
Right, victim blaming.
Whereas attributing the causes to biological or genetic factors tends to lower stigma. It suggests a more compassionate, less blaming view.
Okay, that makes sense. So this really brings us neatly to a critical concept here, mental health literacy, MHL. What exactly is MHL, and why is it so incredibly important when we're talking about OCD and stigma?
Right. Mental health literacy, or MHL, is basically the knowledge and the beliefs people hold about mental disorders that help them to recognize, manage, or prevent these conditions.
So it's about knowing enough to understand and act appropriately.
Exactly. Put simply, it's about having enough accurate information to understand mental health conditions, know when help is needed, and know how to support others effectively. And better MHL is a really significant factor in overall health. It leads directly to diminished stigma, fewer discriminatory behaviors, and more appropriate emotional reactions towards people experiencing mental health issues.
It sounds like the foundation, really.
It truly is. It's the foundation for building a more informed, understanding, and supportive society.
But the reality, according to our sources, is that OCD MHL is actually quite low, isn't it? That's concerning.
It is very concerning, yeah. Current research specifically on OCD MHL is often quite narrow. It tends to focus mainly on those more commonly recognized symptoms like contamination or symmetry.
Right, the stereotypes go.
Which completely fails to capture the disorder's full diversity. And studies show that people are significantly less likely to correctly identify OCD when it doesn't involve contamination or ordering.
Can you give an example?
Sure. One study found that while something like 86% could identify an order-related OCD depiction,
Pretty high.
only 23.5% correctly identified an aggressive-related OCD depiction. That's a huge drop.
Wow. Less than a quarter.
Yeah. And even for contamination OCD, which people think they know, another study found only about 13% of participants correctly identified it based on a vignette.
Only 13%. That's shockingly low for the most known type.
It is. And as we discussed, those media portrayals of OCD as just being quirky or humorous or like normal habits, they just perpetuate this low MHL.
Right.
Remember that finding. Only 14% of participants in one study suggested treatment for someone described as experiencing significant distress from order-type OCD symptoms.
I'm like the public doesn't even recognize as a serious problem needing help, even when distress is mentioned.
Exactly. And the consequences of this low MHL are severe. They lead to really significant delays in people seeking help or sometimes avoiding treatment altogether.
How long are these delays typically?
The statistics are quite startling, actually. The average delay in seeking treatment for OCD was found to be about 3.3 years in Spain, which is bad enough,
Yeah.
but a staggering 17 years on average in the United States.
17 years. That's almost unimaginable, living with that struggle for so long without the right help.
It's a huge amount of suffering. And this delay is particularly worrying for people who have an earlier age of onset because they tend to have a poorer prognosis if treatment is delayed. The condition can become more entrenched, harder to treat effectively.
And it's not just the general public struggling with MHL, is it? Our sources mentioned it impacts professionals too.
Yes, and this is a critical point. Low OCD MHL even impacts mental health professionals. It leads to misidentification and misdiagnosis, especially for those obsessions considered more taboo in society.
Like the ones we mentioned earlier.
Exactly. Like one study reported a shocking 77% misidentification rate for homosexuality-related OCD obsessions.
77% misidentified by professionals.
Yes, and 43% misidentification for other sexual-related obsessions. This directly impacts whether individuals get the right diagnosis and, crucially, the right type of treatment, like ERP, which is specific and effective for OCD. It's a major systemic failure.
Wow. That's deeply concerning if even the professionals are missing it that often.
It really is. And individuals with OCD themselves often voice these concerns. They talk about healthcare professionals lacking knowledge, about frequent misdiagnoses, about having their symptoms trivialized, even within psychiatric care settings.
So the lack of understanding runs deep.
It's a profound issue, yeah, rooted directly in this widespread lack of comprehensive MHL.
Okay, let's now zero in on that specific Prince Edward Island study you mentioned. What did this local research reveal about OCD, mental health, literacy, and stigma right here in the PEI general population?
Right, so this PEI study aimed to get a snapshot of the current levels of OCD, MHL, and stigma on the island. And it wanted to explore how these things varied based on the type of OCD content presented in vignettes, like contamination, aggression, sexual thoughts, and also based on individual characteristics like age and gender.
And they used vignettes like little stories.
Exactly, carefully constructed scenarios. And a really notable strength of this particular study, methodologically speaking, was that they included a control vignette.
A control. What do you mean?
A scenario describing perfectly normal thoughts or behaviors, nothing problematic. This is actually often missing in similar research, surprisingly.
Ah, so they had a baseline of normal to compare against. Smart.
Very smart. It helps avoid misinterpreting responses.
So what were the key findings from PEI? Did they confirm the low MHL?
They did, largely. Overall, OCD MHL levels were found to be low in the PEI sample, which lines up with broader trends we see elsewhere.
Okay. And the link between MHL and stigma?
They confirmed that moderate negative relationship. So thankfully, higher knowledge was associated with lower stigmatizing attitudes on the island, too.
Good. What about age and gender?
The gender differences were significant, mirroring other research. Men generally showed higher levels of stigma than women, and women, in turn, showed higher OCD MHL scores.
Okay.
And the study also confirmed that weak positive relationship between age and stigma we talked about earlier, suggesting older participants tended to display slightly higher stigma levels.
Right. And what about that counterintuitive finding about familiarity? Did that show up in PEI too?
It did, reinforcing that really unexpected result. Individuals in the PEI sample who reported having a diagnosis of OCD actually reported significantly higher levels of stigma and lower levels of OCD MHL compared to those without OCD or those who were uncertain.
That finding really makes you pause, doesn't it? Higher stigma among those diagnosed.
It absolutely does. It really challenges assumptions.
What about the different types of OCD content in the vignettes? How well were those understood?
Yes, delving into the nuance there. The sexual content vignette was the least understood overall. Participants were least likely to correctly identify it as a problem and least likely to perceive a need for treatment.
How badly understood?
For example, a concerning 22.6%, nearly a quarter, incorrectly stated that no treatment was needed for the person described in that scenario.
Wow. Despite likely distress implied.
Exactly. Similarly, the aggression or harm vignette was the least understood in terms of getting the diagnosis right. It was often misidentified as schizophrenia, actually.
Oh, interesting. Trading one stigmatized condition for another, potentially?
Potentially, yeah. In stark contrast, the contamination-related vignettes had a very high correct identification rate, 96.6%.
Okay, so people recognize that one.
And the order symmetry just right vignettes also had high recognition, around 93.3% correct identification. It shows a clear public bias towards recognizing only certain stereotypical types of OCD.
That really highlights the MHL gap for the less typical presentations. And what about that control vignette, the normal scenario? You said that was important.
Yes, this was a truly critical finding, I think. Because that control group, the one depicting no actual problem, they had the highest misidentification rates across the board.
Wait, people thought the normal scenario was a problem? More often than the actual OCD ones sometimes?
Over 50% misidentified it on all 3 MHL questions: problem identification, need for treatment, diagnosis.
That's astounding. What does that tell us?
It powerfully underscores how crucial these control vignettes are in research. Without them, you might wrongly conclude that people are good at identifying certain OCD types, when actually they might just be guessing, or perhaps over-pathologizing any description of intense thoughts or specific behaviors, even perfectly normal ones.
Huh. So sometimes people might just be seeing problems where there aren't any, based on the description.
It suggests that possibility, yeah. It adds a whole layer of complexity to interpreting MHL data.
Absolutely fascinating. Okay, so bringing all this valuable research together, what does it mean for how we can actually actively combat stigma and encourage healthier, more informed conversations about OCD?
Well, the sources point to some clear evidence-based strategies to fight stigma effectively. First and foremost is psychoeducation.
Educating people.
Yes, actively educating the public. Specifically, dispelling those common myths we keep bumping up against, providing factual content, promoting a much broader, more accurate picture of OCD beyond just cleaning and organizing, and really stressing the profound distress the disorder causes. It's not trivial.
Right. Get the facts out there, challenge the myths. What else?
Second is contact. Direct, meaningful contact with individuals who have lived experience of mental health disorders has been consistently shown to be powerful in reducing discriminatory attitudes and fostering empathy.
Contact. So meeting people, hearing their stories.
Exactly. And the research suggests this contact should follow what they call the TLC3 principle.
TLC3. Okay, what's that?
Targeted, local, credible, and continuous. So not just a one-off event, but ongoing, believable interaction. This could happen through things like specially designed smartphone apps, videos of personal stories, or well-planned anti-stigma campaigns that create genuine connection.
Yep. Targeted, local, credible, continuous. TLC3. Got it. That makes sense. Sustained, real contact.
Exactly. Fostering empathy and understanding over time.
You're absolutely right.
Yeah.
And a huge part of that psychoeducation piece has to be tackling those widespread myths head on. Right?
Absolutely crucial.
Our sources highlighted some really stubborn misconceptions that actively harm understanding. Let's just bust a few right now, because these aren't just slight inaccuracies. They're deeply ingrained beliefs we need to challenge. So let's start with the big one. Myth number 1. OCD is just being overly clean or organized.
Right, the classic. And the reality, as we've said, is that this is maybe the most pervasive and damaging myth out there. OCD is a complex mental health condition. It's driven by intense fear, anxiety.
Not preference.
Not preference at all. And while contamination and order can be part of it, the obsessions can relate to so many varied themes: sex, violence, religion, morality, or just that awful feeling that things aren't just right. And crucially, the compulsions aren't just tidying up. They take up hours of someone's day. They severely disrupt their entire life, their relationships, their ability to work or study. It goes so far beyond a simple preference for tidiness.
That's such a critical distinction. It's not about choice. It's about this driving internal force that feels completely out of control. Which brings us right to the next one. Myth number 2. OCD is just a minor personality quirk or preference.
Yeah, And again, absolutely not. It's a real, often debilitating mental health condition. Individuals cannot simply choose to control their distressing thoughts or stop their compulsions, even when part of them recognizes these things as excessive or irrational. It's not a quirk you can just decide to turn off.
Can't just snap out of it. And this next one ties into that idea of control too, or rather, the lack of it, and visibility. Myth number 3. Compulsions are always physical actions.
Right. And the reality is, while many compulsions are physical, like the repetitive washing, checking, ordering we mentioned, they can also be entirely mental acts, internal rituals. Things like silent counting, maybe in specific patterns or to certain numbers, repeatedly reviewing past events or conversations in your head, trying to find certainty or reassurance, or even mental prayers repeated in a very particular, rigid way. These are much harder for others to recognize from the outside, obviously, but they are equally impactful, just as time-consuming and utterly exhausting for the individual experiencing them.
That's a huge point. If it's invisible, it's so much harder for others to understand the sheer effort and struggle involved. Okay, let's tackle another phrase we hear all the time. Myth number 4. Everyone has a little bit of OCD.
Ugh, yes. This phrase, while people often say it innocently, maybe trying to relate,
Yeah, trying to connect.
it profoundly trivializes the actual suffering and the massive disruption experienced by those who are truly diagnosed with the disorder. It dismisses their immense struggles. It inadvertently reinforces the idea that OCD isn't a serious condition, when for those truly affected, it is anything but trivial. It can destroy lives if untreated.
It really minimizes the very real pain and impairment. And speaking of pain, there's often this misconception about the outlook, about whether things can get better. Myth number 5. OCD is untreatable.
And this one is so important to debunk. It's just not true. OCD is treatable with the help of mental health professionals using highly effective, evidence-based methods.
Like what kind of methods?
Primarily exposure and response prevention, or ERP. That's considered the gold standard.
ERP, how does that work?
It's where you gradually, systematically face your fears, the obsessions, the triggers, without giving in to the compulsions. You learn through experience that the feared outcome doesn't happen, or that you can tolerate the anxiety without the ritual.
Okay, sounds tough but effective.
It can be challenging, but it's incredibly effective. ERP is often a key part of cognitive behavior therapy, CBT, which is a widely used effective form of talk therapy. And often medication, usually SSRIs, is also part of a comprehensive treatment plan.
So there are effective tools.
Absolutely. Early diagnosis and consistent treatment offer a very good outlook for managing symptoms and significantly improving quality of life. There is hope.
That's such a hopeful and necessary message to get out there. But what about how people try to cope on their own before getting help? Myth number 6. Avoiding triggers will cure OCD.
Right. It seems intuitive, doesn't it? If something makes you anxious, just avoid it.
Yeah, stay away from the thing that bothers you.
But for OCD, this coping strategy actually tends to backfire. It can worsen symptoms over time, strengthen the underlying fears, and lead to increasing isolation as the person's world shrinks more and more.
So avoidance actually feeds the OCD.
It really does. Exposure, facing the fears in a controlled way with therapeutic support rather than avoidance, is often a crucial part of effective treatment. It helps people learn that their feared outcomes usually don't materialize, or that they can handle the discomfort.
Okay, avoidance makes it worse. Good
Yeah.
to know. And finally, because we've talked so much about how varied OCD is, myth number 7. OCD is the same for everyone.
And the reality, as we've hopefully made clear throughout this deep dive, is that OCD is highly heterogeneous. It looks different in different people.
Right.
Obsessions and compulsions can even change over time within the same person. Symptom severity can fluctuate greatly depending on stress levels and other factors. No two cases look exactly alike.
Which means
Individualized understanding and tailored treatment are absolutely essential. There's no one-size-fits-all approach.
that's a perfect summary of why these myths are so harmful. They promote a simplistic, inaccurate view. Now, shifting slightly, what did the research tell us about the actual experience of disclosing OCD, deciding whether to tell people?
Yeah, the research on disclosure highlights both significant challenges and also strong motivations for why people might choose to share.
What makes it hard to disclose? What stops people?
Well, several factors inhibit disclosure. One is simply not having an official diagnosis yet. People might feel unqualified to claim the label or worry they won't be believed.
Feeling illegitimate.
Exactly. Then there are those harmful media portrayals we discussed. They can lead to self-misunderstanding, making people unsure if what they experience is OCD, or making them feel ashamed and want to conceal the more taboo obsessions.
Right. Afraid of judgment based on stereotypes.
Definitely. And there's also the very real anticipation of negative responses, worrying about workplace discrimination or just being disbelieved or having their struggles trivialized by friends or family. This whole general battle of stigma often leads individuals to hide their behaviors, hide their internal struggles, just trying to appear normal.
It's heartbreaking, isn't it, to think someone would feel they have to conceal such a fundamental part of their daily experience just to kind of fit in or avoid negative consequences.
It really is. But on the flip side, there are also strong factors that facilitate disclosure, things that make people want to share.
Okay, like what?
A big one is reaching a place of self-acceptance with their OCD. Feeling more comfortable with it themselves makes it easier to talk about. Also, a strong desire for support and reassurance from trusted relationships, partners, family, close friends.
Needing connection and understanding.
Yes. And interestingly, the research mentioned the humanizing effect of social media advocacy in online communities. Seeing others share their stories, finding people who get it, significantly reduces feelings of isolation and can empower people to share their own experiences.
So finding community online helps.
It seems to, yeah. And finally, there's often a powerful motivation to simply set the record straight, to educate others about what OCD is really like, to challenge those myths, even if doing so is often emotionally exhausting for the person.
That drive to educate, even when it's tiring. I can see that. The sources also mention something about privacy control.
Yes, that's a really interesting point. It highlights how individuals often manage how they disclose. They might use privacy control, choosing not to reveal the full extent or severity of their OCD.
Holding back some details.
Right. Or they might use less stigmatizing terms to describe their experiences. Instead of saying, I have OCD, they might say they struggle with panic symptoms or anxiety, terms that might feel safer or more easily understood.
Using language strategically to manage potential reactions.
Exactly. And this vividly demonstrates the deep impact of societal perceptions and stigma on how individuals navigate their own narrative, how they manage their personal information, just to try and get by in a world that doesn't always understand or accept.
Wow. Okay, so to try and wrap this up, to summarize our deep dive today, it seems clear that obsessive-compulsive disorder is a truly complex, often incredibly debilitating mental health disorder. And it's one that is still profoundly misunderstood and way too often trivialized by society at large.
Absolutely.
Stigma, which seems largely fueled by low mental health literacy, remains this significant pervasive barrier. It stops understanding, and crucially, it stops people from seeking help.
Couldn't agree more. The research really underscores the vital role of accurate mental health literacy. We need better understanding, more compassion. That's what empowers individuals with OCD to feel safe enough to seek the effective treatments that exist and ultimately to improve their quality of life.
It really does.
And this all raises, I think, an important question for everyone listening. How can you personally contribute to fostering a more informed, a more supportive environment for mental health, not just for OCD, but really for all conditions?
That's the key takeaway, isn't it? What can each of us do? So maybe here's a final thought for you, our listener, to reflect on. Consider the everyday language we all use when talking about mental health. Could even a small conscious shift in your vocabulary, maybe dropping phrases like, I'm so OCD about that, create a powerful ripple effect? One that starts to gently dismantle those stereotypes, opens doors for real acceptance, and ultimately fosters genuine support for everyone who might be struggling.